Hey, everybody. Thanks for joining us. I think that we normally do our APC meetings on Monday, but we had the good fortune of being able to get my good friend. I guess I'm gonna call him my good friend, and he'll hopefully either keep the lie perpetuated with you all or clarify with Dr. Stephen Loyd. Some of you may know the character that Michael Keaton played in Dope Stick. A lot of that was framed around Dr. Loyd's experience. But Dr. Loyd has actually come in now to do I think, some really important work in the West Virginia area. And I want to talk a bit about that. But I want to, and then you don't know this, Dr. Loyd, but I try to say that these conversations are like you and me, or you and I, depending on the appropriate English there, having a cup of coffee on my porch. And so some of the questions, if you don't know the answer to, is okay to say, that is an acceptable answer. But I'm also probably going to talk about some things that you're like, I wasn't ready for that one. I want to talk to you. I know I want to talk to you about West Virginia, but I also want to talk to you about some of the stuff that is actually going on in Tennessee. With Tennessee giving its money back to CDC. I don't know if you know anything about that, or if we can talk about kind of what are some of the needs in Tennessee given what's going on with local and state health departments in Tennessee. But where I'd like to start is for you to introduce yourself to the people and tell the people who you are.
Oh, well, thanks, Tony, and I do consider you a friend, so that's mutual, and thank you for saying that. I'm Stephen Loyd. I'm an internal medicine physician. I've been practicing addiction medicine now for about 15 years. I'm a Northeast Tennessee boy. Jonesboro, Tennessee is my hometown. I've been living in Nashville for about 10 years, and now I split time between Tennessee and Canal Boulevard in Charleston, and really the whole state. I just came from Elkins, West Virginia, and I'm pulled over at not a rest area, but a 7-Eleven, just a little bit north of Charleston in Kanawha County. But I appreciate what Tony had to say. I've been, really interested in the field of opiate abatement, and also the complete care of patients with SUD of any type, but opioids the focus. But we all know that there's other drugs involved, and so by heart, I guess I'm a prevention guy. I wind up talking about medication a lot because it's controversial. I believe that you have to have all hands on deck approach, and that's certainly what I espouse. So I'll talk just a little bit about what Tony said, and well, one other thing. I appreciate the shout out for Dope Sick. First, I want to tell you I didn't make any money off of that, so I don't get paid. I don't get paid or anything like that, and I didn't win an Emmy. Keaton did. I didn't win crap. I didn't feel like that was fair. I had to live through it, and he won an award. So at any rate, but I'm grateful for it. The last time I looked, and it's been a while, but I think about 21 million people had seen Dope Sick. And so just getting the message out there that recovery is possible, and when you have the right set of circumstances, for sure. So I'm very grateful for that, and very grateful for Beth Macy, my friend, who got me involved in that project when she certainly didn't have to do that.
Mhm.
So it's opened a lot of doors, as you all could imagine. So just about the money being given back to the CDC from Tennessee, I wasn't involved in that. That's our state health department, and I haven't been in state government in a while. In Tennessee, I'm the chair of our abatement council, but it is different. It is separate. Our legislature and governor had the good sense to keep it separate from the state bureaucracy. So we are a separate entity, and so I'm not part of that. I'm not sure of the decisions that went around it. So Tony, this is one of those things I just don't know the thinking behind it. I do know that I guess I cringe anytime money goes back. Because I know the need out there, and so that was my knee-jerk reaction. As far as having any more insight on it than that, I don't. Except for really how it affects our population. We have a population of people that use drugs intravenously, and they have higher rates of hepatitis C and HIV disease than obviously a non-using population does. So anytime I see things like that, I'm concerned because it has the potential to limit resources for the people that we're trying to reach. So it does affect me. But I don't have any insight behind that. And the fact that, in our state, even if I was still with the department, mental health and substance abuse service is separate from the Department of Health. And that was a Department of Health thing that I'm like anybody else. I read the newspapers, and the newspapers tell me from our, Commissioner of Health that we have funding to replace that. Whether or
Right,
not that's true, I have not been privy to that, and
right.
that's about what I've got there. So, and
Well, let's do this. I see many people that I know, and again, if anybody has questions, please just put them in the chat, and we'll get to those along the way. So now let's talk about how did they convince you to come get a job here in West Virginia? I mean, because you got a real job, and what
uh,
is your job? How did they
uh,
convince you to do it, and what is it?
well, it didn't take a lot of convincing. First of all, Antonio, I told you I grew up in Northeast Tennessee, and I grew up in the part of Tennessee that is Appalachia. West Virginia is the only state that is totally Appalachia.
Mhm.
Of course, Appalachia is part of a lot of states all the way up to Maine, but I've always looked at our area as it's kind of really its own state. The issues facing Appalachia have they affect us as a whole. No matter if you live in Northeast Tennessee, Western North Carolina, Eastern Kentucky, the whole state of West Virginia,
Mhm.
Pennsylvania, so it's my home, and so
Right.
it doesn't take a lot of convincing there. I spent about every summer of my life from about age 5 till I went to college in Jefferson County,
Oh, really?
West Virginia. Yeah, Harper's Ferry. So
Yeah.
my uncle worked for the Army Map Service in D.C. and hillbillies like me in East Tennessee doesn't realize that West Virginia in that area, the state, the Eastern Panhandle, is just a baseball throw to D.C.
Right.
So he worked in D.C. and lived in Harper's Ferry. So I spent mainly most every summer of my life in Jefferson County and Beckley County, West Virginia. I actually did follow WVU football back in the day. Major
Right.
Harris was one of my childhood heroes. He's a little older than me. As I got older, I got kind of freaked out at how close an age we were. But back when you're in middle school, not that big an age difference. So I have ties to the state. My father-in-law is from Moorfield, West Virginia.
Oh,
Uh,
I'm right next door to Moorfield. I'm in Baker.
Well, my father-in-law is Bill Toohey. He's a retired Marine Corps colonel,
Mhm.
not ex-Marine. He's just retired.
Uh-huh.
He believe me, he'll always be a Marine. But a lot of ties to the state of West Virginia. And it's West Virginia is one of those weird states. Very few people live here, but everybody I run into has ties here.
Mhm.
And so Mike Meat, I think, is on this call. Mike Meat works with Rob Pack. Rob Pack is one of our guys at ETSU, and Rob has deep West Virginia ties. The president of ETSU, Brian Nolan, has West Virginia ties. So, there's just a lot of ties to the state. But really, the thing that got me interested in it was a politician, in all honesty, Tom Takubo. So Tom is the Senate Majority Leader. He's also, I knew him from, I don't know him as a politician. I know him as a doctor.
Mhm.
He was a pulmonary critical care fellow back at ETSU back when I was the chief of medicine in our VA. And Tom was Dr. Takubo was a great resident fellow. Residency kind of separates the timber from the brush, and he was one of those guys you could always count on. And so he came to us from the DO school in Lewisburg and did a pulmonary critical care fellowship, and then came back to his home state and back to Charleston, and really lost touch with Tom after fellowship. And then we ran into each other in DC. We were up there for an event, and they said, "Hey, Steve, there's going to be another doctor here, but he's also a Senate Majority Leader in West Virginia." And I said, "Well, what's his name?" They said Takubo, and I thought, "Well, what are the chances, right?"
Right.
And so Tom, had obviously, kept up with me, and he knew about the dope sick stuff, and so I got to meet Tom, and not Tom, but Tom's wife, and he has 2 daughters and a son. And we just got to talking. We got to talking about Appalachia. I got to talking about the things that were going on in West Virginia, and so I started traipsing back into the state. I'd done work in West Virginia before, Tony. I didn't tell you this.
Mhm.
Back in the day, when we were still dealing with mainly pills, and by the way,
Mhm.
pills are still a problem. We need to not forget that. But you had a U.S. attorney in the Southern District of West Virginia named Booth Goodwin, and then in the Northern District, a guy named Bill Edenfeld, who is actually still the U.S. attorney in Northern District, and so I got involved with those guys in prosecuting doctors who were running pill mills. And so I served as an expert witness, and then Bill Einfeld and I got in a car and hit every hospital up the Panhandle. I don't know what that Panhandle is called, the one on the other side of the Ohio River from Pennsylvania. And so we hit all the hospitals up through there in trying to educate their providers on the proper prescribing of controlled substances. So I have a long history here, right, on all sides of it.
All right. So a couple of months ago, apparently, because you've been in this job now, how long? How long?
I think I'm about midway through my second month.
Okay, so 2 months. So all right, so 2 months. So how many? Maybe 4 months ago, 5 months ago, your phone goes ring a ding a ding a ding, and you say, and the person on the other end says, "Hey, I don't know what they said. You were there. What'd they say?"
Just talk to me, about this position. Now that you cut out there for a second, but I think you're talking about the call that led to this job. Just talking about the position that, the head of ODCP. It's been empty for a while, although Rachel Thaxton, had done it for 2 years, really, and in my opinion, did great work. From what I've seen, and so just talk to me about that, what it would look like, and what my ideas were, and so Tony, I mean, this is no secret, and I know Mike Meets on here, and I've used Mike and Mike's work extensively with the Recovery Ecosystem Index. That there's no secret of what the buckets are. I mean, I see these landmark studies coming out, and it's the buckets, right? I mean, we all know what those are. I'm interested in how to allocate those dollars into those buckets and into those strategies that are going to give us the most amount of bang for our buck. And Senator DeCubo knew that. So did some other senators. I did an interim session in May in Marshall 2 years ago and introduced the idea, and they liked it. And so what I'm talking about, and what I keep talking about, is using something called systems dynamics to model your system instead of the traditional needs analysis. Right? We're going to do a needs analysis. Well, needs analysis can be part of it, but what you want to do is take that needs analysis and fold it into modeling, computer modeling, and using artificial intelligence and machine learning to predict, on how to allocate your dollars within these strategies to get the results that you're looking for. Right. And I learned about system dynamics from a case that I worked with a group called Janus Consulting down in Mobile, Alabama, in Nevada, and that's where I learned about it. And one of the people there who was involved with it said, we could use this in abatement. And I got to thinking about it, looking at it, because Tony, I've been to your conference, the Syndemic Conference, right? And we talked about these things, and we know the strategies, but how do you allocate the funds within those strategies to help you shrink the pool of people using, right? I mean, that's the goal. And so every state that I looked at, including my own, we use something called the SWAG method. And the SWAG method is scientific wild ass guess. Okay. And so I can't even watch a football. I love football. I can't watch a football game now without seeing AWI analytics, right? They tell me what chance Christian McCaffrey had of scoring on that toss sweep, right? Right. And so to not use predictive analytics modeling, and then here's where the kicker is. Let's look at things on the backside of it and start to measure our outcomes, so that we can move funds from things that aren't having the desired effects to things that are, right? And so that's where I became interested in it, because a lot of this money across the country have been allocated directly to counties, and that's not a bad thing, right? I'm not against that, but this is the complex issue. And I go to these counties and they say, we don't know what to do with it. We're just going to leave it at the bank. We're afraid if we spend it on this, we'll get in trouble and have to give it back. So I hope Mike's still on here, but I always start, hey, if you don't know anything else, right? You don't know, your rear end from a hole in the ground, right? Look at the Recovery Ecosystem Index, right? Look at that. And at least you can get a start, because the folks that put that together have my highest degree of respect, and it's usable, right? I mean, you've got a score there from 1 to 5. You've got these 3 big categories that shows you your assets. And Tony, this is one of the things I get confused about, because, I'm in Kanawha County. Say I was back in Marion County, where I was earlier today. That's a small county, right? But even they have assets. They have some things in their county that is, what Rob and Mike and those guys call recovery capital, right? So how can we help you take a look at the recovery capital you have, and then start to build your system of care around resources that you already have, right? I mean, to me, that's the idea.
Well, that's so. If somebody should have told you, I interrupt all the time. But
that's okay. I know you. It's fine.
So here's the thing. So we're up here with it, like with AI analytics, with being able to do systems evaluation and systems analysis, and using that and having that be actually computer generated answers, right? And I think that there is some worlds in which that gives you very detailed and specific information. But
Right.
some of the people on this call only want to know a couple of things. How do I apply for that money? How do I get that money to my organization? How do I get that money to my county? What is my county's resource level to do this? And I think that, one of the, every state, this better than most, every state has kind of done this a different way. Most people are using one of three systems, right? So they're either creating a foundation, or it's going to go through some health departments, or, they're going to do some direct funding. So one of the things I think that is interesting, and I'll say it that way, in West Virginia, is I'm not so sure everybody knows what's happening with the opioid abatement money. And so one of the things I wanted to talk to you about is what's going on with it. How do people access it? Can people access it now? And that's one set of questions, is around just the practical. How do I fill out an application and get some of the opioid settlement money? Because I think that that's how it is in most people's minds. I think in your mind and in my mind, it's this big other thing. It's this big process. It's this big system that is impacted by other systems, right?
Yeah. No, it absolutely is, Tony. And this is also part of what I'm learning, because the state I came from, I know how we allocated it in basically two ways. One, directly to the county funding. And one of the things that I love about Tennessee is our transparency. KFF actually wrote an article on that, about the transparency we have, because I mean, I can tell you down to the penny how much each of the counties are allocated, and how much they're allocated last year, this year, and every year that we distribute funds to them. So first of all is knowing, first of all, is it going into a foundation, or is it split between a foundation and the counties? Now, if it's going to your county, then always start with the mayor and the county commission. I'll guarantee you they know, when they get a check for $235,000, right? I mean,
Right.
and so start at the county level. If you're looking at it from a county level, and their states, being allocated directly to the county, start with the mayor and the county commission to see what the process is for spending that money, because you can't just spend it on anything. That money has to be spent off of something called a remediation list that was agreed to, no matter the state.
Whoa. Back up. Slow it down. Put it in reverse. What's the remediation list? And do we want to talk about Exhibit E?
Right. So remediation list, most everybody on the line is familiar with the tobacco settlements, and basically they went to do whatever states needed done. Right. Very little of it went to dealing with, nicotine addiction and the damages from smoking and prevention. Well, with this at the national level, the settlement dollars, they can't just be spent on anything. Now, some states that had money directed from the fund directly to the counties off the top, that money can go from anything. Tennessee was one of those states. But if the money flows through the foundation, or it flows through the state, then to the counties, then they have to go off the remediation list. And remediation list, we can think of it like a plan, right? This is all the different parts that we're familiar with. Basically, four big categories, right? Prevention, education, treatment, harm reduction, and then all the strategies within that. And so the remediation list is published. I mean, I have a copy of it on my phone. But you can see what counties and what it can be used for. And I've looked at it. It's looked at it extensively. Basically, it is an abatement plan, and all the different things are included in that. And if you want to spend your money, then it has to be spent on this. And I haven't looked at it specifically in West Virginia yet. I hadn't been here long enough, because the West Virginia First Foundation I'm not a part of, although I do like the leadership very much. But in Tennessee, if you spend that money on anything off the remediation list that flowed through us, then we can actually come back after.
Right.
And
so let me so go back to that, right? So wait, I thought a part of what you're doing isn't associated with the West Virginia First Foundation.
No, I'm not on the West Virginia First Foundation. So
tell the people, don't tell me, tell the people.
Okay.
I don't want to pick up what I'm putting down, because I don't
I'm looking. I'm looking at all their faces on my screen, so I thought I was telling them.
Right,
So, except for the ones who won't show me what they look like in
right,
3D.
right.
So, in West Virginia, the West Virginia First Foundation is, controls these funds, and they are not part of, DHHR. They're not part of the Bureau of Behavioral Health. They're not part of ODCP. They are an independent group of people appointed for that. Jonathan Board is the director, and the chair is Matt Harvey. And so they direct those funds. I am not part of that group. ODCP's job, the Office of Drug Control Policy, is a policy position to give our legislature, our governor, direction on policy to address drugs and alcohol use in the state of West Virginia. So that's my goal. I will be a resource for Matt and for Jonathan as that organization, the West Virginia First Foundation, goes through their process of allocating these funds. Now they've already sent a lump sum of funds to each of the regions within the state of West Virginia. They did that at the last meeting, and I think folks on this call who are from West Virginia are familiar with that. Then how they allocate those funds going forward is what they're addressing now. So I am not in those meetings. I'm in the meetings they have that people can come to, but I am not a voting member. I am not a part of it outside of being available for direction when asked.
Okay. So, all right. So in other words, don't pick up a phone or send you a text or send a courier pigeon to you saying, hey, Dr. Loyd, I need to get some of that West Virginia opioid abatement money.
Now, I will never say that. I'm not responsible for the direct allocation of funds. However, I'm always interested in ideas that people are doing, right? Because I mean, part of my job is to look at, what are you doing? Where does it fit into our system? And so, I mean, I'm always in. I would never tell anybody not to text me. If you're looking for direct allocation of funds, that's not me.
Right.
Right. And matter of fact, ODCP has a very limited amount of funds for anything around like that. That's going to come from the Bureau of Behavioral Health. However, I'm looking at a system of care. And, the things that I've seen in West Virginia already, in all honesty, there's a lot of impressive stuff here from a programming standpoint. And Tony, I have not sat in the office on Capitol Street in Charleston. I mean, I am in my truck. If I could show you it, I promise you I live in here. Okay. And so I'm getting out and looking and seeing, what this looks like at the grassroots level. We have MAT behind every bar in the state of West Virginia. That's monumental. We have one person over all incarcerated individuals in the state of West Virginia. We're not dealing with, 55 individual sheriffs who have a fiefdom over their jail. We have a lot of advantages in this. And so what I look at is, how to take the things that we already have in place, and then where the gaps are, and then how we fill those gaps. And I hope going forward that part of my role with West Virginia First Foundation will be to share with them some of these gaps and ideas that I have, but I'll do that when asked.
Right. So one of the things that is come up in the chat is this idea around what are we going to do about harm reduction in the state? What are we going to do? I mean, I know that right now there's a bill that the governor has put forth to allow, I think it's Marshall University, to do this pilot around methadone treatment facilities. But, right now there's a moratorium on methadone treatment. And if we don't figure out some systems, which is what we're talking about, to address harm reduction, to address MAT, and when I say address MAT, and this is what I'll tell anybody that'll listen, is that I believe a couple of things. I believe that the idea that MAT providers, that's buprenorphine, Suboxone, and methadone, particularly those that are seeing fewer than 300 patients, have not been engaged in HIV, Hep C, and PrEP uptake. So that's one of my big questions for you, is that we've got to figure out a strategy to educate them and pull them into this continuum of care around this syndemic of HIV, substance use, and hepatitis C. That's one question for you about what's the best way for us to do it. Then the next question for you is, what are we going to do to try and overturn this moratorium on methadone? I mean, our rates of substance use disorder have not dropped enough where I can say we don't need every tool in our tool belt. We don't need every, bullet that would be in our arsenal to fight substance use disorder, and give everybody as many options as we can. What do you think that we can do on both of those fronts? What can we do on the front around the existing moratorium? Is that something your office is looking at, thinking about? When we think about what we need to do to look at how we do more harm reduction programs. I mean, you know better than most that 2 years ago, we had 18 syringe access sites or syringe, safe syringe sites in West Virginia, and today I think we have 8. I know that was a lot of questions, but I think you can handle it.
No, it is a lot of them. But Tony, just from a Steve Loyd philosophical standpoint, okay, first of all, addressing harm reduction. I don't know how to treat dead people. All right. And I talk about that all the time. So, in any plan of action, you have to figure out how to keep people alive, Tony. And once you keep them alive, how do you keep them disease free? There's this thing out there that says, well, I'm not at risk of HIV and Hep C because I don't use intravenous drugs, or I'm not a, male homosexual, or whatever it is,
Mm-hmm.
and that's actually not true. We're all at risk. We don't live in a vacuum. We live in community, and people's risk of getting those diseases are directly proportional to the viral load in their community, and we all understand and know that. So the lower the viral load in your community, the less chances you have of getting it. And so that's where I stand on that, Tony. I am I'm a harm reduction guy first, because you have to keep people alive and as disease free as possible. And so as far as that, the number of programs, there's some things behind that I completely, can't sit here and say that I completely understand, but I will be an advocate for these going forward, from my position, because I know what a difference they make. Now, when you start talking about methadone, I think we need all hands on deck. I got into recovery through the abstinence-based route. I tell people all the time, I was born on third base and thought I hit a triple, right? I had the best care that you can get because I'm a doctor. Most people don't have that level of care. Most people are stigmatized. Most people are fired from their jobs. I never missed a paycheck. I got world-class help. And more importantly, I got help with my underlying trauma issues of physical and sexual abuse, right? Mm-hmm. And so that's what I got. Most people don't get that. And so medication is a big part of that. Methadone is a big part of that, particularly with fentanyl. So I'm going to talk about methadone in general, right? In general. And in general, for the most part, when I see it, it turns my stomach. Mm-hmm. Right? Because they're not part of the treatment system. What you're talking about, if I get a patient coming into my clinic, Tony, and I'm running a methadone clinic, it's got to be more than just about handing them a cup that has 120 milligrams of methadone in it.
Right.
Right. And I'm not against that, because I know for sure that that's going to keep them alive. I mean, I get that, right? It's going to quell their cravings, but I've got the opportunity to screen them for Hep C, to screen them for HIV, to educate them on those 2 diseases and prevention going forward. I've got an opportunity to educate them on PrEP, right? I've got an opportunity to provide, reversible long-acting contraception to our females who are in that category, and to educate them on their risk of giving birth to a drug-dependent baby when they're on these medications, right? To me, so that's part of comprehensive care. And so those are things that I'll be an advocate for until they throw dirt on them. And right. I don't care if I'm in West Virginia, California, New Mexico, or San Juan, Puerto Rico. That's going to happen. Right. And so we have to be able to.
So Dr. Loyd, let me ask you this. So what kind of leverage, pull, opportunity to change mindset on Capitol Street or in the office do you have? Because I like you because you're a right-minded, right-thinking kind of guy. I mean, we probably don't agree on everything, but I think we agree on most things. Right. Now, the thing is that how do we get state officials to come along with us? Is it that we have to convince them that there's an ROI, a return on their investment? Do we have to convince them that if they provide the prevention care and treatment that we're talking about, they actually save, not just save lives, but they save money? And, and that's one of the pieces that we are really trying to do with MAT providers in West Virginia, Kentucky, and in Virginia, is that we're saying, I don't want to approach you from a systems perspective related to public health. Let's talk to you about an economic bottom line. Let's talk to you about how much money you can make if you test folks for care and then you bill it to Medicaid. If we can test people for HIV and bill it to Medicaid, test them for Hep C and bill it to Medicaid, link them to care and bill it to Medicaid. Wow, look at that. You made a whole bunch more money than you were going to make before. So is it that we have to figure out new systems to have conversations with the provider? But then we've also got to be able to kind of have conversation, I think, with local and county officials. And I'm going to say this one last piece, and then I want to hear from you. And that is this, is that I tell people all the time when they kind of ask why is it that this region, the Appalachia region, 26 million people, 423 counties if you use the ARC metrics, right? Why is it that we haven't been able to get a handle on all of this? And I tend to say a couple of things. One is that this region has been dealing with an opioid crisis or a drug using crisis for 30 years, 3 decades. And so I've got that. And then on top of it, I always do my little train analogy about all of that. And I'll save everybody's ears today. But I really think that one of the things that happens is that 30 years of a crisis, people don't have a whole lot of bandwidth. Then you add COVID on top of that. That happened. Then you add on top of that the economic downturn that happened as a result of COVID. And so now you want me to come along and tell you that you've now also got to put skin in the HIV, Hep C PrEP game. And the truth is that I just believe that the roughly 20% to 25% of new HIV cases and the 50% of hepatitis C cases that we say we can't find in this country, I think that they're sitting in those MAC clinics. So I've got to get them to test. I've got to get them to have conversations about PrEP uptake. And so, but I also got to get other people to understand that, for example, I don't know if you went to Healing Appalachia the last couple of weeks ago, but it was about 20,000 people, all predominantly white, all predominantly some connection to substance use disorder somehow, some way. And I looked around and I'm like, those are 20,000 probably naive screening patients for HIV and hepatitis C. There's 20,000 people that could get a conversation about PrEP, which they probably have never heard of. But I got to do several things. I've got to make them understand that this is about them too. It's not a they problem. It's an us and a we problem. I got to get them to also understand that, guess what? There are opportunities for treatment. There are opportunities for prevention, and there are opportunities long scale for long acting opportunities in the biomedical space. I know that was a whole lot to say. So how do we do it? How do we fix it? Because I gotta get those 20,000 people to see themselves as a part of this syndemic. I got to get those, and I've got to get their providers to see themselves as a part of our response. How do we do it?
Tony, it's part of what I do. I show people that we don't live in a vacuum. Everything you said is true. And, so there's two ways to go about it. When I got involved with drug dependent babies, there's a section of our leadership out there that cares genuinely about human beings. And so you can take that approach. Nobody wants to see a baby withdrawing. And then there's another segment that cares about, what the balance sheet looks like. And so you show an ROI. That's the beautiful thing about everything that you've talked about. We can show a really good ROI on all of it. Oh, by the way, we were human beings and we helped our fellow man. About that, right? I mean, these two things go together. I was with RFK Jr. a week ago on Monday, and I don't know if people know this. He's been in recovery himself since 1983, and he was talking about allocating funds to help people into recovery as part of complete recovery, like what we're talking about, right? And somebody asked him how you're going to pay for it, and he had some ideas on how to pay for it that I'm not going to get into. But he had this line. He said, if somebody gets into recovery, they pay for themselves. And I think everybody on this call knows that. So how do we get people to see that? So part of the mess here in the front seat of my truck is just that, right? It's what I'm trying to do. I've got to take both approaches. I mean, and you've seen my talks, Tony. You know what I do.
Mm.
There's a horrible mass murderer out there who I won't honor by naming, who said that one death is a tragedy, a million deaths are a statistic. So what
Right.
I try to do is I try to take a story, one story that everybody can relate to, and they can see their son, their daughter, whatever, and I try to get them to buy into that story and get the heartstrings, because that's what we're talking about. But then on the flip side of that, showing why it's worth our time economically to invest in it. And Tony, it is everything that you just mentioned. So let's just look at Hep C for a second. We're going to pay for Hep C one way or another. You know it, and I know it. Okay. And a liver death, as an internal medicine
No,
hospitalist,
it doesn't make sense to me.
I do not want to die that way. Okay, that's a horrible death. And a third of those Hep C cases are going to lead to fulminant hepatic failure in the end without treatment, and we know it. We are going to pay for those with state Medicaid or Medicare dollars at some point. My point is, we're already spending the money, we're sending it on the back end. So what we have to do, Tony, is to get them to see exactly what you're talking about and spend the money up front to identify these cases and take care of them early, because it's going to be a whole lot cheaper to pay for it now rather than later. And so that's what I try to do. That's my approach.
Now listen, and people sometimes think I'm wackadoo when I say the following statement. I know you can't. I know it's difficult for you to believe that anybody thinks
It is. Yeah, it's tough. It's tough.
But here's what I also think, and this is a core belief of mine, that when I look around who some of the laws that get passed, whether that's a reduction in harm reduction, or whether that's an OTP moratorium, or whether that's whatever it is that we think is not going in the direction we wanted to go in. I often sit back and ask myself the question, when and how do we talk to these legislators about their own trauma? Because like I said, we've been dealing with this for 30 years.
Right.
Right. So I can't imagine that these same people haven't been impacted in their social, familial, economic, educational, somehow network. And so if it was their mama who didn't take care of them because she was on drugs, or their grandmama who didn't do something or whatever, they've got some level of residual trauma. And maybe this is why we see some of the laws that we see. What do you think we can do? What do you think we can do with members, whether that's at the state level or whether that's at the county level? How can we have conversation with them about their stuff? Because their stuff impacts how they make decisions.
It does, Tony, but I've never had much success with that and pointing it out to them. What I've always tried to do is use my story to get them to connect with it. And it's recovery, right? We know that we can't, I know I can't change somebody else. I know that. But what I can do, I can share my experience, strength, and hope, and start to let them see the parallels between us. And then, hopefully they'll step out. And there'll be some people, Tony, who won't. I mean, the hardest thing to do is look in the mirror and look at ourselves. I mean, I want to look out here. I want to, point to this or point to that. Most of the time, mine's in the mirror. My response, my trauma response. And I had one earlier today, since you mentioned that. I had a trauma response. Just how I was raised, the trauma that I faced, and then how I responded to a situation that happened to me earlier today that came out of my work. So I haven't had any success of getting other people to, hey, can't you see this in yourself? Because the defense just goes up. What I try to do is I try to open myself up, let myself be vulnerable, and then draw people in that way. And it's the only thing I've ever had success with, realizing that there's going to be a portion of the population that we're trying to reach, with this message that's never going to get there for whatever reason. And I have to accept that. But then move on to people and find champions that can do otherwise. Like I told you today, I found a judge, up in Elkins, West Virginia, of all places, who I sit there and I listen to him share. And it's just amazing to me the things that he sees and what he's opened himself up to. So now he and I are going to team together to leverage ourselves in trying to reach other judges, law enforcement, and then people in the medical profession. So that's our approach. And if it's okay, Tony, there's a couple of things here I wanted to address. I scrolled down through the chat. And so I want to make sure I address them because we're going to, we're out of time here in a minute. So somebody asked me what I meant about pills. Guys, prescriptions are still bad. Okay. That hasn't gone away. Now, most of our people now are dying of heroin and fentanyl, but, and I'll say very little heroin and a lot of fentanyl, but but you got to remember, new initiates don't go out, for the most part, and shoot fentanyl the first day. And so we, one of the things that bugged me was all the support we had for reeling in the prescribing guidelines of the CDC a couple of years ago, and even some people that I know and love were advocating to reel those in. And I'm telling you that we don't need to reel those in, because most prescribers out there, still are doing the things they were doing. I'm not talking about pill mills. I'm talking about, garden variety prescribers. And so we still have a prescription pill problem. We do not, matter of fact, our computer modeling, if I had some of my colleagues on here, they would tell you that when we model the nation, we model the whole nation as part of our, part of our case in the state of Nevada. This prescribing is still a problem. And so we don't need to take our eye off of that, because, the new initiatives are coming into our system for the most part still by being prescribed, prescription opioids. And I'm not talking about getting rid of them. I'm talking about properly prescribing. So that's the reason I mentioned that. The second thing I wanted to get to was, I thought it was a great question. I've got to be able to find it again here, Tony. I'm so sorry. It's going to take me just a second. I got to go back to my chat. And it was so good. I wanted to see. I explained that one.
Yeah, somebody asked if they can get a recording of this, and the answer is yes. You can get a recording of this when it's done.
Yeah. Let me find this one. Oh heck. But somebody addressed. I think it's Abby. Abby said, "I worry about the lack of humanity when involving artificial intelligence." Abby, that's not what I'm getting at all. Humanity is one-on-one level. It's about meeting people where they are. It's about forgiving people unconditionally. It's about demonstrating mercy. It's about loving your neighbor. That is at the provider level. Artificial intelligence, I'm talking about looking at the raw data. And when you start to look at outcomes and start to look at, the programs that are having an impact when it comes to people actually getting into recovery, right? And there's some indicators we can look at from that. I was with the Jobs and Hopes program yesterday, and one of the things they look at are people who no longer require. I forgot what's the new term for food stamps. Tony, what's it called?
Food stamp recipient?
It's not. I call them food
SNAP.
Yeah, SNAP. It's looking at the number of SNAP recipients. So if you have somebody come into your program and they're using, they're getting SNAP benefits, they get into recovery, they get a job, they drop off SNAP benefits. That's a positive outcome. That's somebody, you would look at the ROI on that. Now those SNAP benefits are available for somebody else. Now that person is working, they're actually paying into the tax base. I mean, that is a positive ROI. And so I'm not talking about the lack of humanity at all. And I'm not talking about turning people into ones and zeros. You can't do that. Because the opposite of addiction is not recovery. The opposite of addiction is community and relationship. I'll believe that until the day I die. But I do think that we need to take a look at using analytics to help us better spend our money. And so, Abby, what I mean by that is, say we've got a program out there somebody's doing, and we have our system modeled. We can say, okay, I'm going to invest X amount of dollars in this jail program to provide MAT. We can actually plug that into the model that has been created based on our current system, and look and see what the impact of that investment dollar is on shrinking the number of people who use drugs in the long run before we spend $1. Right. That's what I'm talking about, and how to allocate it. Because if you sink all of your funds into just a couple of strategies, your chances at a long-term outcome of what you're looking for are going to be markedly reduced. So if you took all of your money, and I'm a huge proponent, guys, do not read this the wrong way. Okay. I know what this is going to sound like. If I have $10 million and I stick it all in overdose reversal drugs, right? That's a good thing. Okay. People's lives are going to be saved. Everybody on this call knows that. Right. So I explain it as a bathtub, and this bathtub is full of water droplets, and those water droplets represent people using drugs. And you've got a faucet coming in that's filling that tub up, and you got a drain coming out the bottom that people are falling out of it. Right. There's only a few ways to exit that tub through the drain. Right. 1, you get into recovery. 2, you bounce back and forth. 3, you die. So if we take all of our money and we stick it, and our goal is to reduce the number of droplets in that tub, right? That's our goal. You take all your money and you stick it in overdose reversal drugs. Again, we're going to save lives, and I'm not saying we need to let people die. Hear what I'm saying. What does that do to the number of overall people in that tub? It paradoxically increases. Why? Because some of those that didn't die flip back and forth. Some of them get into recovery, right? But they're still using the ones that are going back and forth. And we did nothing to address things on the front end with regards to prevention and preventing new initiatives. That's what I'm talking about.
Well, you kind of get to, I think, what my big question is, right? My big question is I think that we have multiple streams of, people always say, you need multiple streams of income. I think that we have multiple streams of solution. But I think,
Yes.
right, but I think that many people only think one way is the way. There's still a lot of people out there that believe that abstinence only is the only way to go. There are
Right.
a lot of people out there that don't believe that folks should be on MAT and then be able to go and get a union job. One of the things that I think is the other big challenge here is that we have to figure out the economic impact of this on us, on the community, on the town, on the state. I remember, and I want to say it was 2016 maybe. There was an article in the Wall Street Journal, and it talked about I want to say it was an 836% increase in hepatitis C rates in West Virginia, in part due to the Oxycontin crisis, but just because of the lack of screening. And I guess that's a question I have for you. What is the plan for the state to have a broader HIV, a broader Hep C testing program? What is the plan around PrEP uptake? What's the plan?
Right. And Tony, that'll be what I'm a part of in working with the groups that I'm going to work up with, and this being one of them. I can't tell you what the plan is in West Virginia yet because I haven't figured it out, and the people I work with haven't worked with them enough to figure it out. But I can tell you, in Tennessee, what we did was we put it in our OBOT regulations. And if you're going to have an OBOT and you're going to do this, these are the things you're going to do, and we're going to come behind you and look at it and see if you did them. And we get to that point. You can do things for two reasons, Tony. You can do them because it's the right thing, and you can do them because somebody tells you to, and you got to, right? And so I'm more, again, I'm a recovery guy, attraction rather than promotion, right? But sometimes you got to tell people, and and sometimes you got to make people, and there are ways to do that. And I'm not saying that that's the route we're going to take here. I'm just saying that in other places that I've worked, that was what wound up being our ultimate solution. So if you're going to provide MAT services on an outpatient basis, there's some things that you're going to have to do in order to get a license to do that. And I think that's a good thing because now we can start to control a little bit about the care that's delivered rather than simply writing a medication. Again, I'm not against that. We know the medication saves lives. I'm not against that at all. Okay. But there's more to it than that. There's more to it in helping people build their lives in recovery with the things that they need in the social determinants of health, disease prevention, screening, treatment up front rather than, when their CD4 count drops to 20. Right? Those kind of things. And so, Tony, there's ways to go about that, and that's going to be part of what we look at here in West Virginia. Now, the other question, I would scroll back and found it. Somebody asked me about the use of injectables in the CJ population. So I'm assuming they're meaning criminal justice. Look, guys, it's just us on this call, okay? If I had my druthers, we would use injectables on everybody, right? I mean, you pretty much take diversion off the table, although I never underestimate the intuitiveness or the ingeniousness of people who use, right? Very smart. But you cut it down drastically, right? And we can get it off the table. It's $1,600 to $2,000 a shot. I'm sorry. The companies out there, they send me emails all the time wanting to talk to me. Hey, I'm sold. You sold me. I love your product. It's wonderful. It's $1,600 to $2,000 a month. Okay, come on. Buprenorphine, Suboxone, methadone, cheap, right? We've got to have something that I can't help you, right? And if you're going to target that to private insurance, then you're going to leave out the population that we're trying to reach. And I'm not knocking people who have private insurance who need treatment for SUD, but we're talking about Medicare, Medicaid, and the uninsured, okay? And if we're talking about a criminal justice population, which I have said this for years and I will continue to say it, until we address it in folks behind bars, it doesn't make a difference. You're not going to move the needle if you don't address it behind bars. And so we're going to leave out that population. If you want to bring your injectable to the table, lower the damn price.
And I think that's true with treatment for hepatitis as well as PrEP. But I think the other pieces of that are, and I think you hit on it earlier, is a we versus them mentality. So many people in our communities don't believe that they have a risk of HIV, Hep C, or that PrEP is a value proposition for them. And I think that that's one of those other things that we really have to do, is really to get people to understand. Again, I keep coming back to that 25% of HIV cases, 50% of Hep C cases that we say we can't find. I think that we're not looking where we think we should be looking. I think we're looking at people who are the same old people and don't understand. Like I said, there were 20,000 people that went through the gates at Healing Appalachia. I wonder what the ratio of folks there who have been screened for HIV, have been screened for Hep C, or had a conversation about PrEP.
Yeah,
And I
no,
and
I
I'm
don't
gonna go
disagree.
to, yeah, that number was low.
Yeah, it is low, and I don't disagree. But one of the things I want to make sure I get an opportunity to say before we end is this, and I'm not meaning to hackle anybody, because I'm guilty. I'll just point the finger at me. I'm guilty. Um, uh, is when we're there are things that everybody on this call feels passionately about, and there are legislators and there are people in positions of power that feel the other way. And as long as we're throwing rocks and calling them names, I've never gotten very far with that.
Correct.
I've had to find common ground, and there is some common ground. I think for the most part we do care about what happens to other people, and even people that I have absolutely disagreed with vehemently. Right, I've never gotten anywhere by calling them names. We have to find the common ground and then suit up and show up. Right, and that's what I've done. I remember back when I was first started working in drug courts, and I couldn't get any of them to use MAT, and they would actually send people back to jail with me sitting on the drug court when this person was doing really well on medication. Right, and
Right.
I could have sit there and called them dumbasses and everything else in the book. Right, I could have easily done that. What I did was I kept suiting up, showing up, advocating for our patients, and finally we had this kid that everybody loved, and he just couldn't do it. And the judge looked over at me and said, "Steve, do you think this person would do well on medication?" I said, "Judge, I almost guarantee it."
Right.
And we never had a problem with MAT in that court again.
Mm-hmm.
Guys, you eat an elephant one bite at a time. We have to take us calling people names, calling them out. That just hasn't worked for me personally.
Right.
And what I
Yeah,
would ask,
no, I always say it might be that we agree that we both like fancy socks, or that, we have something in common. I think we always have to leave with a reason to come back. Right. Like,
right,
it's like, I remember that you like socks, or I remember that I know that I had a meeting with a guy when we were down in Burke County, and I was like, you know what, you like watches. He and I didn't agree on very much, but I could talk to him about watches later on, send him a couple of
right,
emails, and he wanted to talk some more. So I, I,
yeah,
I agree with you. I think it's that we've got to find the place that is a common ground, commonality. But it's like I said, and also remember that these folks have been dealing with this for 30 years, and there's no way that they've all dodged this being a very personal issue for them. Now,
no,
I had one person here, but I think she may have gone. Lynn O'Connell, did you leave? Yeah, I think she jumped off my screen, so I think Lynn may have left. So I was going to ask Lynn about her research project, but then I was also going to ask, I know that we had a question from Laura at Health Right up in Morgantown about whether or not, are you doing like visits? Are you going to organizations to see what they're doing? How do folks get you to do a stop by, not a drive by? That's different.
no, it is different. So, I mean, I'm doing, I take the approach I've taken everywhere that I've been, Tony, and is I just suit up and show up and go. And I've kind of got a priority list. For me, this is just my priority list. Criminal justice is in a lot of what we've talked about here today. We know how prevalent it is in the criminal justice population. So, if you'll reach out to our office, Dora Radford, somebody that I've learned to love really quickly. Dora is wonderful. She scans my email. She pulls out things that she knows that I'm very passionate about, and everything we've talked about today, guys, is on my list. You all know that. And then, I need to know where you are, because when like when I was in Clarksburg, I needed to know some other things in Clarksburg besides the judge I was going to see. So while I was up there, I could look and see, look and see those. I visited Recovery Point in Charleston yesterday. Loved it. Right. Just loved it. I've been to Parkersburg. Visited several places within Parkersburg, Huntington, multiple places in Huntington. I really want to get into southern West Virginia, McDowell, Mercer County, and start to look at some of the things that are happening there. So if you'll send an email to Dora, and tell her what you would like. I got a whole stack of papers here that I prioritized them and told her where to work them in, and I'm doing my best. But guys, the only way I know to figure out the system is actually suit up, show up, and go look at it. And that's what I'm doing, which is why I'm coming to you from my truck.
Perfect. I appreciate you. We've got about 5 minutes left. If anybody's got a question, I ask you to put it in the chat. And we can probably get one question asked and answered. If not, what I would like to do is ask you a question.
I'm looking on there to see the QRT, the Quick Response Team at Huntington. Actually, whoever wrote that, Connie, I'm going to be in Huntington Thursday and Friday of this week. So Tony, if you will shoot Connie my contact information. Connie, just text me. I'm going to be in the car most of the day. Dora's email. Gosh, I wished I knew it.
We put it in the chat. We put it in
all
the
right, all right, good.
Good.
And Martha, I will not forget the Northern Panhandle. I've been all the way to the top of it, and I promise you, I will not forget it. Like I said, I'm doing my best and rolling tire rubber off my tires, but I will get to the Northern Panhandle for sure.
Perfect. I just want to thank you for taking the time out. I was very excited when I heard about you coming. And I think I was more excited because I always say, I think you're a guy that just gets it. Right. And I think that it's like you've talked about today, we have to figure out, it's actually written in the National AIDS Strategy that they say that we have to take a holistic approach, meaning that government can't fix it alone, federal can't fix it alone, academics can't fix it alone, researchers can't fix it alone, people with lived experience can't fix it alone. And that's the thing I always appreciate about you, is that you really want to get everybody engaged. And that there's not one single answer. And there's a multitude of answers. I think that people are really would like to see more information, and I'll get ask Lee or Lavina to send you a note about it, about what do these analytics mean? What are the variables that you're using to kind of figure this out? Because, for me, I want to figure out if we test 20,000 people at Healing Appalachia in 2025, can we make a statistically significant impact in the number of people who we know, or the number of people that we can get on PrEP or whatever? And so I'm actually going to ask some of the folks on my team to reach out to you to maybe help figure that out. But I also think that the idea of what we need to do with the Appalachian, but not just the Appalachian opioid remediation efforts, but with the opioid remediation efforts overall, are critically important right now, because those dollars, I think people see them and think, well, they'll be there forever. They won't. And most people are front loading these dollars, meaning that first 3 to 5 years, there'll be a lot of money, and then there's a precipitous drop.
Well, and Tony, something not to forget about, you got to remember, this ball game ain't over, right? The faucet ain't turned off, because there's other parties out there that are going to be called to the mat. Right. So I agree with you. Some of this money is front loaded, but I'm also privy to information to know that the well hadn't run dry yet. Okay, right. So the Supreme Court ruling that made the Sacklers' personal finances subject to this is one thing. You've got other groups of people out there that played a significant role in this that are starting to be targeted, for their part of it. So we'll keep hope there, and we'll keep up the pressure there. And I promise you, I'll be working hard in those areas to make sure those things happen, so we can get every dollar we can, because no matter what we do, we're not going to bring people back from the dead, Tony. And so there's no way for us to make people whole, as you well know.
Right. I want to thank you for, again, taking time out of what I know is a crazy schedule.
My pleasure.
Right. And again, thank you so much. And we will send out a recording of this, and I think that we put your email, or not your email, because nobody is going to get the email back. We put, I think it's Dora's email in the chat, and I can say she's very responsive. So,
Yeah. Dora's wonderful. Dora's best quality. She cares about people, you know, and you know, like the people I love, and it's why I'm on this call. I know I've looked at the names. I know a bunch of you, and I know you care about people, and I've always got time for that.
Perfect. And
All
again,
right. Thank you, Tony.
thank you, sir. Have a good one.
All right.
Drive
All right.
safe. Put your
I'll do
seatbelt
it.
on.
Bye-bye.
Put your seatbelt
I
on.
will. I
All
will.
right. Okay. All right. Bye. Thank you, everybody, and thank you for joining us. And again, my good friend, Dr. Stephen Loyd, doing what we need people to do on the ground. Thank you, everybody.